I'm excited to be with you today at Eyes on Dry Eye 2022. It's my second appearance, and I'm covering a topic that I think will be relevant to all of you. It deals with some of the more difficult to manage cases, and I think it gives us an opportunity to learn not just for managing those cases, but also for understanding the underlying etiology and managing even some of the less complicated cases. For those of you who are not familiar with me, my name is Epstein. I practice in Phoenix, Arizona. Lovely Phoenix, Arizona. It's almost sunny today in a practice within a practice called the Dry Eye Center of Arizona. I just do dry eye and ocular surface disease in that context. So in that sense, my practice is limited. So without further ado, let's talk a little bit about my disclosures. Yes, I'm sure you know this is a necessity today in the current regulatory environment. And those of you who know me know that I pretty much say exactly what I think, regardless sometimes of consequences. I've been very fortunate. My lectures have been sponsored, research have been sponsored, and a number of companies are nice enough to sometimes listen to what I say. They don't actually always like listening to what I say, but they often do. So, I've learned a lot and hopefully shared a bit along the way. So let's talk about some of the, I think, complexities that we deal with every day in managing dry eye patients. I know it's a super hot topic and everybody would like to be a dry eye expert, but certainly expertise as in anything else comes from, I guess, being immersed in it and doing it all the time. And for better or worse, that's been my lot in life. And interestingly enough, COVID has actually immersed me even more because I think some of the less complex patients, have deferred examinations and put things off, and we've ended up with a really challenging, patient population. And for me, challenging means opportunity to learn. So I approach things, in a very straightforward and simple way. Whenever I possibly can, I have a foundational approach, which I'll share with you in a minute. I think that's important because, it's the foundation, the basis of how I manage all patients, and it gives me a platform that I can extend from to manage some of the more difficult patients. And this presentation is really focusing on those patients that just drive you crazy. You make a little progress and they kind of fall back. Sometimes you can't make progress and it doesn't seem obvious as to why. And this can be an extremely frustrating experience for the clinician, and certainly is for the patient. Dry eye is very much a product of our environment, both endogenous and exogenous. So it can wax and wane. We'll talk about that. We'll talk about flares, and we'll talk about representative cases. And putting this course together, I really thought about how to do it best. And I realized the best way is really to look at specific cases and learn from them, pretty much as I think I've done. It's an approach that I use to share with colleagues what I've managed to figure out, and hopefully you'll never see an eye like this staring back at you from a slit lamp. So this is something many of you may be familiar with. It's the Dry Eye Center of Arizona Home Treatment Instructions, and you can see there's a lot of things on it. I don't use all of them. In most cases, most boxes are not checked, but it is the basis of how I approach virtually all patients, at least initially. And I think I'll call out the hallmark treatments, which include 16 to 1800 milligrams of a triglyceride-based omega-3 with a minimum of a 3-to-1 EPA to DHA ratio. And this is something that patients take daily. It could be spread over the day, or it can be taken all at the same time, which I typically do. And just because I'm lazy and I want to get it over with. I think the underlying reason is relatively straightforward. The glands need EPA primarily in order to function. Some will disagree, but that's been my experience and has been a successful approach for me. and makes a big difference. I liken it to wood for a wood stove. You can have a beautiful wood stove and freeze to death if you don't put wood in it. Hypochlorous acid is extremely important. We'll talk about that during the rest of the presentation when it should be used. In some ways, it's almost a miracle drug or a miracle solution that's been around for many years, primarily for surgical disinfection initially, but it's found many uses more recently. Warm, moist heat for many patients, if inflammation isn't present, warm, moist heat actually can make inflammation worse. And for some patients, a variety of medications, which are ever growing, which is great. We're seeing a significant increase in our armamentarium. So chronic refractory dry eye is problematic, especially if you have won the trust of the patient, which is the first battle. And some of the conditions they have are difficult to manage. Graft versus host, persistent staining or SPK, patients who have autoimmune disease, we'll talk about that as well. And good examples, are the patients who have been miserable for 20 years with Sjogren's syndrome. And now that you're the dry eye expert, it's up to you to solve the problem. And I think we can. We've had good success in managing Sjogren's patients. And I'll share some of that background with you, how I arrived at some of the things that we do. But there are lots of contributing factors and conditions. Certainly in the Phoenix area, we have horrible air quality, an extremely dry environment, and a lot of heat. And we're fairly high up as well, even though we're in a valley. So, the outside environment challenges the ability of the body to maintain balance, to maintain homeostasis in a challenging environment. Acute refractory dry eye and ocular surface disease is something that comes and usually with rapid environmental shifts. This is a classic allergy patient that has borderline dry eye and suddenly gets thrown over the edge. And the reason they get thrown over the edge is it's inflammation on top of what would be inflammation if it progressed. And now all of a sudden you're dealing with, a significant amount of inflammatory mediators. The tear film becomes an issue because the dilutional reserve of quote unquote dry eye patient. And that's whether you look at things simplistically, which I don't think is an appropriate way of looking at it, as evaporative versus aqueous deficient. Either way, you have a decreased dilutional reserve and an increased volume of allergens in a given volume of tear. So we need to identify the underlying causes, and we need to be aggressive in systematically addressing them, sequentially if necessary, or globally, depending on what approach and what medications you're using. And these patients require multiple different medications or therapeutic interventions, and those have to be staged properly, timed properly. There's almost a cadence to it, and we'll talk a little bit about that. And my favorite, I think, contemporary thinking is that we have a medication that was approved by the US FDA not that long ago, I guess probably about a year ago, maybe a little longer, and it really brought into focus the patient who has flares. Now we know, many of our dry eye patients would complain of exacerbations, and we kind of mush that into the background of their, misery. But suddenly we had a medication that was designed specifically to treat it. And I find it interesting that when we have medications or techniques or procedures that treat things, suddenly we identify them better, focus on them more, and understand them because now we can fix it. Now we can make a difference in the patient's life. So even the best managed patients, the ones that you're proud of, and the patient comes in and says, oh, Dr. Epstein, I can't tell you how appreciative I am. The difference between my life when I first came here and today is tremendous. Even they, fall from grace and they have issues. And one of the most important things about dealing with flares, and we'll talk a little bit about it, is that you need to both educate and empower the patient in controlling it themselves. So we now have the ability to give them the tools to control their own flares, which I think is a very, very important element in the overall management of these patients. So let's take a deep dive. I love these graphics. These are great. I usually use white slides. I'm a minimalist. I like a white background. I usually don't appear as a talking head either, but I kind of like this, this thing. It's, kind of reminds me a little bit of the 70s, and at the same time is like modern. So let's talk about SPK. SPK is one of the most maddening conditions that the expert on ocular surface disease has to deal with because it doesn't want to go away. In fact, it rhymes. SPK does not want to go away. And it represents a chronic instability of the tear film, and it eventually leads to surface damage and inflammation as well. Chronic surface exposure, is one example. We see that sometimes in nocturnal exposure. Tear chemistry is altered in the process. Many of the patients complain of light sensitivity, which I know all of you are aware of. And this is something that is seen most often, by far most often, in chronic inflammatory disease associated with systemic autoimmune disease. And sometimes the autoimmune disease isn't, very clear cut. It's not like the patient comes in and has a diagnosis of rheumatoid arthritis and, they have joint deformity and they have, ocular surface disease. We have patients that have rheumatoid arthritis by diagnosis, by, blood workup. And, joints look fine. They have no systemic or rheumatologic correlates, but inflammation, is kind of like a honey badger. It does whatever it wants, and sometimes it'll just attack the eye. And one of the ways it lets us know is by damaging the surface. Toxin exposure could be, an acute precipitator of SPK. Radiation or actinic damage. You've all seen welders burn. We've managed patients who have had sort of misguided radiation therapy that unfortunately involved the eyes. In fact, I wrote an article years ago on using high permeability GP lenses as artificial epithelium after removing the patient's epithelium because it was unmanageable without that approach. And certainly with disease, which we'll talk about in more detail in a little bit, is a precipitating factor because of the exotoxin that staph overpopulation produces and the digestive enzymes, the lipase in particular. And these are examples of, just disrupted surface conj and cornea that are fairly typical. And these always correlate with patient misery. We have, patients who are invariably miserable when they see, experience this type of surface damage. So one of the ways that I think has kind of fallen a little bit by the wayside, although I know many of you are probably still using it, is doxycycline. And doxycycline, as you know, is a systemic antibiotic that has anti-inflammatory properties. And it's actually quite remarkable because it does its job in a number of different ways that, unless you're an aficionado of doxycycline, you probably may not be aware of all of it. There have been studies that show that it's effective as an anti-infective on lid flora, even when the lid flora is somewhat resistant to doxycycline. It also has, as I mentioned, profound anti-inflammatory effects in a number of different ways. So it reduces staph population, as I said, among all species that it targets, even resistant ones. It inhibits collagenylytic activity. Collagenylytic activity, collagenase is one of the ways that those nasty little pits form on the surface of the eye. It inhibits polymorphonucleoside chemotaxis, so it inhibits inflammatory cell chemotaxis to the ocular surface. And inflammatory cell chemotaxis brings with it a wealth of damage. It also improves meibum quality, reduces saturation of the meibum, so it makes the meibum more effective at creating an environmental block. Promotes healing of damaged epithelium. My particular preference is 50 milligrams BID for 30 days, and then once a day for 60 days. And I prefer the monohydrate form. I find it to be more effective, and it's systemic. Any number of companies or manufacturers produce it, and it's inexpensive. There is a small potential for complications, but it's relatively rare. Topical steroid drops can be very helpful, but they're a double-edged sword. As you know, topical steroids can, promote corneal melting and, impede healing, but they can be very, very effective, especially at rapidly shutting down the inflammation that leads to surface damage. Loteprednol, as I'm sure most of you are aware of, is one of the safer options. Relatively low complication profile, but very, very effective. In some ways, probably effective as prednisolone acetate. But when you stop the steroid, if you don't understand and target the underlying problem, the SBK comes back, and certainly steroids are not for long-term use. I do use it for pulsed use. That would be 4 times a day for 4 days, 3 times a day for 3 days, 2 times a day for 2 days, and then once a day and then stop. Or sometimes, 4 times a day for a week, 3 times a day for a week, and so on. But, that is the only way I would consider using it, a general steroid for long-term use. We can use steroids for flare control, which we'll talk about, a specific formulation of loteprednol. Amniotic fluid drops have also been very helpful in my experience. This is something that's produced under FDA clearance. There are, I think, 2 companies that do it. Regenerize is a company I've used for many, many years, and I've had, phenomenal success with it. Amniotic fluid came from the observation that in utero operations, heart operations, for example, could replace a valve in a neonate and or I should say fetus, and the baby can be sewn up and delivered 2 or 3 weeks later without any evidence of a scar. Scarless surgery that plastic surgeons would describe it as. And in fact, it was a plastic surgeon that first came up with the idea for using amniotic fluid for initially for dermal filler for patients that had traumatic accidents and deep gashes and wounds, and then slowly moved towards eye care. And now it's the main focus of that particular company. So there are a variety of growth and healing factors. And it can be very, very effective. There are 2 different strengths, what they now call the Pro, which is their full strength, which needs to be refrigerated and a little bit harder to handle and more expensive, and their light version, which works well for more prolonged care. And I find this to be more effective than autologous serum, but that's my experience, and your mileage may vary. Okay, come on, computer, cooperate. We have a number of different RX medications that have been introduced. Lifitegrast was actually, I believe, the first to be approved by the US FDA for the signs and symptoms of dry eye. And it works in a very unique and very interesting way. It's a surface active anti-inflammatory that blocks T-cell adhesion by mimicking ICAM, the adhesion complex of intracellular adhesion molecule. So basically, you have free-floating ICAM-like elements that fill in the binding site of T cells, preventing the T cells from adhering to the surface and then promoting inflammation. And the clinical trials showed efficacy with corneal staining, and we've had some success. It's not my first choice necessarily, unless I'm using it to treat overall inflammation and dry eye symptoms. It works on dry eye symptoms much more rapidly. SBK takes longer, so don't throw the baby out with the wash water if it doesn't work initially. Give it some time, but it's not the most effective at SBK, but it does work well. Certainly one of the most effective ways of managing SBK is amniotic membrane, particularly cryopreserved. I've had amazing response to it. And in addition to SBK for microbial keratitis, we just had to go in last night for a physician who had a corneal ulcer that was, would have been frightening, 20 years ago. But with amniotic membrane, I think he should end up, relatively unscathed, even though this was a large paracentral ulcer, and it promotes healing. It works wonders for SBK. It works well as an initiator for neurotrophic keratitis, which we'll talk about. Works very, very quickly. Dehydrated membrane sometimes has to be used because of comfort reasons or timing and staging of examinations, but it's not as effective in my experience as cryopreserved is. And what's nice is this is a very safe option. I know with bandage contact lenses, which we'll talk about in 2 seconds, you're worried about the potential for infection, but with amniotic membrane, it actually is anti-infective, and it's anti-infective properties, so it's exceptionally safe. Bandage lenses is something I really want to highlight because people are sometimes afraid of putting a bandage contact lens on an eye that's surface is damaged. Au contraire, it is one of the best ways of managing SBK, even on a chronic basis. It has to be removed at a specific time period. For some patients, that will be a week. It should not be removed every day. It needs to be slept with to protect the eye 24 hours. Typically, most patients are wearing it for at least a week, and some cases it will go as far as a month. And you need to discuss risk to benefit ratio and the potential for complications. Patients need to have your cell phone or some means of reaching you urgently if things go awry. But interestingly enough, in doing this for many, many years, rarely have I seen an infection occur in an eye that would be worrisome even without the lens. The lenses actually do well and protect the eye and promote healing, and can be a pathway to long-term improvement and management of these patients. Scleral lenses are the ultimate separator between the ocular surface environment and the external environment. It works extremely well for SBK and even more serious surface conditions. We use it in graft versus host, and when patients are just unmanageable. It's somewhat of a last resort, but it's quite amazing. It requires significant skill to fit. It's not, in my opinion, not a simple put in some fluorescein and guesstimate. You need either an OCT or profilometer or something of that sort if you really want to be skilled at it. And you need to deep dive. You need to have someone in the office who really embraces scleral lenses so they become truly expert in it. Problems include cost. Vision care insurance typically will not cover ocular surface uses, dry eye and SBK and the like. And the patients also have to be willing to care for the lenses and able to care for the lenses, but it can be a lifesaver. It can give these patients their lives back. Now, let's talk about something that makes me cry. And I suspect it probably makes you cry because patients come in and they go, I'm totally confused. I've been told, by 3 other doctors that I have dry eye, and look at my eye. And, we've had patients come in with golf rats soaking. I mean, these poor people, it's just chronic tearing, turns their life upside down. Sometimes it causes, massive dermatologic condition. The reason why that occurs is because we have 2 different tear systems, reflex tears and basal tears. And reflex tears kick in when the body senses that something needs to be addressed that requires an emergency eye wash. Essentially reflex tearing is a built-in emergency eye wash station. Really brilliant engineering. Problem is when it's going all the time, it creates a lot of issue. And it's typically associated with just an unstable tear structure. And that's how we usually address it. However, you have to be careful to not miss lacrimal obstruction. If you can stabilize the tear structure, and there are ways of doing that, which, is, I'm sure, been discussed many times in this, amazing program. And, I know it's one of my favorite topics, but the excessive tear flow will diminish very rapidly the associated problems like periorbital dermatitis and, the chafing and things that these poor patients experience can go away. Simple treatment can usually make a tremendous difference. It's actually quite impressive, but you can be fooled. Sometimes, you're off treating the patient by improving the stability of the tear film, and you're just not making any progress. And you take another look at their puncta, and, you will see, as in this one, it's completely sealed over. Some of these patients will need probing. Some of these patients will need additional treatment and some referral to ophthalmic plastic surgeons for a DCR, a Jones tube placement. And that's something is an absolute last resort, because if dry eye is the driver, once you put in the Jones tube, you're out of control. And a couple of years ago, there was an open letter from a group of Australian dry eye sufferers who were being Jones tubed all over the place down under, and their lives were just, completely disrupted. So you're the manager here, so you make the call in terms of what the appropriate treatment is and refer accordingly. But some of these patients do need surgical intervention. The vast majority not. I would say maybe 1 out of 10 requires even probing. Now, one of the most overlooked things that we see, and I thank iPlastics for letting me borrow this photo. And I literally just saw last week a patient that had this much exposure. It's hard to believe. And the patient was, unaware of it because sometimes what happens is these patients are neurotrophic, which I'll talk about in a second. But it is by far one of the most under-recognized major contributors to dry eye signs and symptoms. And the first thing I ask the patient, let's step through your day. When you wake up in the morning, is it the best time of day? Or is it the worst time of day? And many of them will say, oh my God, I wake up in the morning, I can barely get my eyes open. I literally have to pry my eyes open to get them open. I wake up in the middle of the night, I'm putting in drops. So the patients will often make the call before you even look. But the way I make the call, the diagnosis, is I have them tilt their head back about 20, 25 degrees and just, close their eyes like they're going to sleep. And then I get a little bit lower, bend down a little bit, use a transilluminator. And when you see glistening from, what should be sealed eyes, then it's that they're not closing fully. And even the tiniest little crack can lead to major drying and exposure. Staining also, although this isn't foolproof because this type of staining pattern, which is pathognomonic for exposure, will disappear after a couple of hours as the cornea rapidly heals, especially if the primary problem is exposure and dry eye is a relatively minor one. But this can turn the whole day topsy-turvy just by starting the day off at a deficit instead of recovering and recuperating overnight. Desiccation, by the way, doesn't always happen in eyes that don't close. For example, in babies, we'll very often hear complaints from parents. If you search it on Google, you say it's a common question. My baby sleeps with her eyes open. A stable tear film and desiccation often will not occur. And again, this will disappear in the afternoon. And one of the ways of, kind of estimating what's going on, especially when the staining is corneal, is to check the Bell's phenomenon. Grab the lids, have them forcibly close their eyes, and the eye should shoot upward and outward, which is the classic Bell's phenomenon. Patients who have Bell's palsy, we just had one just a couple of weeks ago. Interesting guy. He had one of the vaccines, I think the Moderna, and developed Bell's palsy, which is a known complication of pretty much all vaccines, but certainly the COVID vaccines. And he developed exposure at this, shortly before that he had cataract surgery, and so trying to figure out why he had corneal edema, which he shouldn't have had, with the staining pattern, which had to do with a secondary surgery to grab a piece of cortex that was floating around, and trauma to the endothelium on top of exposure was a bit of a challenge, but had an abnormal Bell's. So always check. That will explain exactly why the pattern you're seeing exists. And here we have a patient where you can see really, really dense staining in that pattern. And this is a patient who is neurotrophic. In fact, my young, brilliant associate, Dr. Corey Lappin, and I are working on a number of papers, this being one of them. We think neurotrophic keratitis is a primary finding in some of these really dense SPK patients who look like they have exposure. And the exposure itself may actually cause neurotrophic keratitis. So, it's a chicken versus egg. But one of the things you should always check for is corneal sensitivity. You can do it with a Cochet-Bonnet anesthesiometer if you have one, or you can do it with a cotton wisp, from a cotton swab. And both conditions need to be treated. You need to treat both the exposure, the underlying dry eye, as well as the neurotrophic keratitis. And I know he's done some amazing courses on NK that I would urge you to tune into. Primary treatment, are not goggles, not for me. They were for many, many years. These are silicone goggles that are made by IECO, a wonderful company in Temecula, California, that make a number of products for dry eye. And what they do is establish an environmental barrier. With the advent of high-low night, which was originally called Vita POS, Vita Boost, I called it. They changed the name because of the POS acronym apparently had different meaning in the US than it did in Europe, and now it's available in the US. It's a paraffin-based ointment, a very creamy paraffin, and paraffin doesn't stick like petroleum. I hate petroleum ointments. They're terrible. They contaminate the tear film and you can't get rid of them. Paraffin, if you use it right, is almost gone in the morning. It also has vitamin A, which helps reconstitute the tear film. It's regenerative. And the other effective treatment is something called Siccasan, Siccasan, which is available on Amazon from a European company, actually Austrian company that manufactures in Slovakia, I believe, and it is a viscous gel with dexpanthenol and carbomer that works in slightly less severe cases. Sometimes they need the mask as well, in addition to one or not both, one or the other of those two choices. And the reason why I'll use the gel first is that it's least noxious and least persistent, and a high-low night is extremely effective. I find this effective as the goggles, but sometimes, like I said, they do need both. So let's talk a little bit about neurogenic dry eye. And as I mentioned, Corey Lappin has done an amazing job with an article and, coursework on this. It's an area of interest in our practice, and we talk about it all the time. A lot of things we talk about all the time. So neurotrophic keratitis is well recognized. It's very classical. It has 3 stages, and it is not recognized as being on the spectrum of dry eye. And frankly, it is. And in fact, in process of actually writing up a paper on neurogenic dry eye, and neurogenic dry eye is basically dry eye that comes from a disruption of neurologic innervation, and this can occur from prolonged chronic dry eye in a more conventional sense. Sometimes it presents because many cases it's just a wiring issue, and many of these patients start with staining, and then they'll move on and they'll actually develop what would be considered classic neurotrophic keratitis, NK. Neurogenic dry eye, by the way, is a term that's used in the veterinary world, and that has to do with, it's a horrible autoimmune disease that dogs suffer from. But I think there are articles that have been written about neurogenic dry eye, at least technical articles, scientific articles, but they're hard to find, and it hasn't really reached critical mass yet. But it's one of the underlying causes of what we would call more traditional dry eye. Certainly, the treatment with oxervate, I can't pronounce the surgermin, the non-brand name, but it's only one. It's the only one in the class, and it is literally game-changing for patients. Here's a sterile neurotrophic ulcer. You can see it's beginning to heal, and we initiate very often with amniotic membrane. This is a SPK. Nothing seems to be contributing. There's no autoimmune disease. You really don't even have severe dry eye symptoms. And when you check corneal sensitivity is decreased, and this can progress very, very rapidly, become much more dense. We had a patient that went from this to that neurotrophic ulcer you saw at the beginning of this segment of the presentation, and very, very rapidly. And it's sometimes very frightening, difficult to manage. You still need to manage them, as a dry eye patient, but the underlying cause is hyposthesia due to essentially a wiring issue. And sometimes that wiring issue can occur in isolation. We've had patients that have had retinal surgery, buckling surgery, where there's nerve damage. Certainly in NK, we see patients that have had damage to the trigeminal nerve, sometimes from surgical mishap. And this is treated with amniotic membrane, especially as in the more severe cases in anticipation of using a product like Oxervate. And here you can see that classic rolled edged ulcer. This is, something that's already crossed over. And again, I can't underscore enough the importance of checking corneal sensitivity. Easy to do, takes a minute, cotton swab, create a small wisp at the front. Oxervate, I think, is going to be in much greater use as they begin to realize more and more patients suffer from a wiring issue. A lot of dry eye has been misunderstood to be inflammatory, which it's not, or of other causes. And the reality is it's just a wiring issue because the entire system is networked, and that's important. This is, by the way, after treatment. This was that patient with the large neurotrophic ulcer who originally presented as a classical dry eye patient. And as I mentioned, need to look for underlying causes, whether they're surgical, infection, or sometimes idiopathic. We just don't know exactly what it is. More often than not, it's bilateral. And when I say bilateral, it can be asymmetric, which can fool you. You just say, wow, this is weird. It's unilateral, but it's not. It's just waiting to I guess, pop up and disrupt your day. We had that patient that we looked at with the big neurotrophic ulcer. She had almost nothing in the opposite eye, and then when we got the bad eye, this eye straightened away, and she had virtually no staining at all. The other eye had dense staining, and she said, it's funny, my other eye now feels terrible. This eye feels great. So, something to keep in mind. Now, you're probably thinking this is weird. Why are you talking about staph lid disease? This is certainly not a chronic, horrible problem, but I think it is grossly underestimated as a cause or a contributor to dry eye disease that drives you crazy, because we don't recognize that when you have an excessive amount of bacteria on the ocular surface in ocular rosacea or in severe meibomian gland disease that occurs chronically over time, what happens is the microbiome shifts, and we have a significant increase in staph. And staph do what staph do. They grow, and they also keep away invading species, which is why under normal conditions we call them normal flora, and we welcome them because they keep away Pseudomonas, for example, which would be devastating if we had high volume of Pseudomonas on the lids. But the exotoxin they produce is extremely irritating and sensitizing, and they produce lipase. Lipase breaks down lipids in the tear film. And what are lipids in the tear film? They're structural, and they have a barrier function as well. So this can actually create long-term, chronic, very difficult to manage dry eye signs and symptoms. And you're thinking, oh, it's MGD, and it's I don't know why their eyes are always red, and which is one of the most difficult things to manage of all. Even when you look at the lids, you're thinking, oh, they have ocular rosacea, and you're not putting two and two together. It's the lipase breaking down the tear film, which is destroying the structure of the tear film. So staph lid disease is a primary cause of red eye complaints. Exotoxin, as I mentioned before, is designed to protect the turf. We sometimes see this, especially in contact lens wearers with sterile infiltrates, although you can see it in the peripheral cornea, even in non-contact lens wearers. And a giveaway sign is saponification, soap making, frothing in the tear film, which we'll see either in the corners or at the lower lid margin, because gravity will allow it to collect. And it's soap. And what does soap do? It breaks down lipids, and what do lipids do? They protect the tear film and stabilize the tear film. So this is, the gift that keeps on giving. It's the cycle that doesn't go away. Lid hygiene is extremely important in managing it. And I said I was going to mention hypochlorous acid. Major breakthrough. I spray it directly onto the patient's closed eyelids and have them flutter as they look up to spread it, and count to 10, give it time to work. It gets neutralized very quickly, but it reduces staph overpopulation, inactivates the toxins, which reduces the sensitivity and the redness and the irritation, but also completely breaks down the lipase, which breaks down the tear film. So that in and of itself is one of the most effective ways of managing the results of staph overpopulation, which is exceedingly common and unfortunately often missed. So let's talk about flares. Flares are interesting things. Dry eye flares represent a very, very complex, multifactorial presentation of a very, very complex multifactorial disease. And if you simplify it, what you're looking at is something that is a failure to maintain homeostasis, which is a process that exists within the entire body to maintain balance despite all kinds of internal and external challenges. And that's exactly what happens, in the eye. And some of these patients do okay. That's why suddenly a patient goes from happy, comfortable, no problems at all to a dry eye sufferer. And sometimes they go in and out of it because the body wants to recover. And in fact, regaining homeostatic balance is, one of the most important things. In fact, the majority of our patients either stay in homeostasis or will regain homeostatic balance. And those patients, they experience flares. When flares become more chronic and homeostatic balance can't be maintained, then we have inflammation. And inflammation is a hallmark sign of that. And that needs to be treated by reducing inflammation as well as addressing the underlying cause of the problem. And then we have the subset that I talked about before, the patients who have inflammatory disease. And the problem with flares is it drives patients batty because it's unexpected. They don't know when it's going to come. They don't know when it's going to go. And we need to help them control it. And I kind of talked about that before. This particular formulation of loteprednol was approved by the US FDA for the signs and symptoms of dry eye for use as a rescue medication. So it's used for up to 4 times a day for up to 2 weeks at a time. Why do I think it's the best treatment for these patients? Well, first of all, it's FDA approved, and steroids do have a complication profile. This has an extremely low complication profile. I'll even use it cautiously with steroid responders, and it counters flares very, very effectively. It's rapidly acting. It uses a very advanced drug delivery system, so a relatively low concentration of loteprednol gets to the target tissue and quiets everything down. And because the patient now controls their flares, it has a very, very positive psychological and clinical benefit overall. And this really, to me, is a good summary of where the dry eye patient lives. The majority of patients live within, blue sky homeostasis. They go out in a dry environment. They go up to Denver where the altitude is higher, or Phoenix where it's particularly dry, or Las Vegas, and their eyes put up with it. They go to Tampa where it's very humid and they go in and out of air conditioning, their eyes put up with it. But what happens is maybe when they're in Tampa and they're going in and out, or in Singapore, where I first kind of figured this out, and they're going in and out of dry versus not dry, they just can't maintain it and they break down. Temporarily, they break down. And then we have the patients who have autoimmune disease, and the body controls that too. Homeostasis is still working in the background trying to get things back in order. But the patients who have flares are the patients that are kind of in that middle third, 40%, not the ones that are chronically inflamed, that where they have really severe surface disease because of typically autoimmune disease or a systemic condition. So, and these patients can be managed so wonderfully with that type of approach. Hopefully that has covered a lot of things and given you grist for your thinking mill. If you have any questions, I'm always reachable, art@epstein@gmail.com. I'll ask that you please use Eyes on Dry Eye 2022 if we don't cover anything during this course. I want to thank the entire Eyes on Dry Eye team for the unbelievable job that they've done in putting not only this program, but all of the Eyes On programs together. They've taken education into the 21st century, and I think they've helped advance our profession. So thank you for attending. Thank you for your attention. And I'm sure I'll see you in the future courses and hopefully in some meetings coming up. Take care.
Hi, everyone. Thank you so much for Another awesome lecture, Art. I really appreciate you, especially taking on this topic. This is not an easy lecture by any means. We've all been in this situation where we see these folks that we go to our usual bag of tricks, and we think we kind of knocked it out of the ballpark, and the patient comes back in 6 weeks later for their follow-up, and they're not doing much better. And then we're kind of backpedaling a little bit, trying to figure out, what did I miss? What are some things that, I should probably pivot to maybe? So really thank you for taking this on. Can you just kind of speak to us just in general terms, your usual, sometimes the knee-jerk reaction might be panic. What would you say is kind of what you should do in that situation when you get that patient back in your chair?
No, I think panic is a fair response in many cases. Panic makes you inventive. It's the mother of invention. It's interesting. Probably the best example is a neurotrophic keratitis patient that didn't start as neurotrophic keratitis. That started as a dry eye patient that wasn't particularly compliant. She was doing reasonably well, ended up with IPL. She comes back for, I think, her second IPL, and she has a big sterile melt, and it's like, and you go, whoa, where did that come from? And now suddenly you're in a totally different universe from where you started. Originally, I always recommend, stick with the basics, do the things that work for patients as soon as you figure out what it is that they need, whether it's, an omega-3 or, the appropriate artificial tears supportively, or, anyway, in the situation like that, I had to pull out a number of different things from my bag of tricks. We pulled out amniotic membrane to, minimize the ulcer, or to deal with the ulcer, which was, quite disturbing. And then got her on oxybate, which works, miraculously in those cases. And, the question is, what was it? Was this dry eye that, was just chronic and converted to NK, or was this actually a case of NK that mysteriously, had waxed and waned, and is really, dry eye is a variant of NK, that can, be relatively minimal, outside the normal boundaries of NK, which is well defined. And so, it's left me, when you go home thinking about things and, waking up in the middle of the night, thinking about them in terms of where they fit, then that you're probably, on doing the right job.
Absolutely. Absolutely. And I think that's really such an important thing that you just hit on. Sometimes we have to kind of just keep in mind there's a full continuum of a lot of these processes that we're looking at a point in time. And so NK is not going to necessarily be, sort of, and in fact, in my experience, it's never really sort of complete anesthesia. There's usually a little bit of a, some of these patients can have some sensation, but this marked asymmetry in that kind of is a big red flag sometimes. What do you find to be your sort of your drops, or the patients that will probably benefit from something like an amniotic membrane, in addition to these patients that have NK? What are some of the other patients that might fall into the category of folks that would benefit from using amniotic membrane?
Well, you've alluded to something that I think is extremely important. There's a lot of overlap simply because, the underlying disease process is often not well understood by us. We're actually treating things almost very specifically when the problem is much broader than that. I often tell patients, dry eye is a wiring problem in many cases, and when we talk about wiring problems, we scratch our head, what the heck does that mean? But, we've seen patients that have had, retinal surgery, buckling surgery, that have reduced sensitivity in one eye. Whenever you see unilateral dry eye, you always have to wonder, like, what's going on? And corneal desensitivity or hyposthesia is often a cause. So for amniotic membrane, that's, one of the most incredible developments in my career. We just had a 50-year-old physician who came in with a big corneal ulcer, and I was confident that we would save the day because we had amniotic membrane, which is anti-infective by itself, with some of the modern 4th generation fluoroquinolones. Polytrim is an add-on for gram positives, and he's going to end up with almost perfect vision, which was unheard of when I first started. You'd look at something like that and you'd say, boy, this person's going to be 20/80, 2100, 2200. So certainly for microbial keratitis, SLK, it can be helpful. It helps promote healing and normalizes the ocular surface. SPK, as I mentioned, that's very, very helpful. It can reduce SPK, although that tends to be transient. I like cryopreserved much better than dry in general. I think it's much more effective, although sometimes you have no choice for comfort reasons or for patient management reasons. And, in general, when we actually have significant corneal defects, recurrent corneal erosion, when we have loose, kind of ratty epithelium, sometimes it sloughs right off, amniotic membrane goes on, patient comes back, 20/20 vision, happier than a pig in a poke, because you've resurfaced their eye. So it's magic. I mean, it's magic in a small little container.
That's awesome. I mean, I could sit here and talk to you for another hour.
I know.
I really appreciate this.
No, I'm honored to be here. I can't thank you enough. This is a phenomenal program. Just great.
Thank you so much for doing this, Art. I look forward to learning from you and many other things, in the future. Thank you so much for taking this topic on and being a part of the program this year. I really appreciate it.
Thank you. My pleasure.